and establish a program to provide long-term multidisciplinary follow-up of successfully treated patients at the treatment center, membership of a collaborative group, quality program and improvement of quality and safety, and access to instruction and learning activities for hospitalized children and adolescents. And I'm very proud of this because at CCCL from the very beginning we have had with Mrs. Makarim and Mr. Hassan educational activities for these children, so we really fulfill all of those criteria. But these are the US guidelines. The NICE document, which I advise all of you to read, it is a very nice document, went through seven quality statements. And these have to do with children and adolescents, or adolescents and young adults. And the first one is that children and adolescents with cancer should have their diagnosis, treatment, and support agreed and delivered by a cancer site-specific multidisciplinary team and a teenage and young adult multidisciplinary team. 2, children and young people with cancer should be offered the opportunity to take part in clinical trials if they are eligible. The others are pretty self-explanatory, but I want to focus on statement 5. Children and young people who have had a central nervous system malignancy should receive a specialist neuro-rehabilitation care package, and we are uniquely poised to do this here. And these are very important. This document is 50 pages long. They go through these different quality statements and what are the achievable goals and why they are needed. And I recommend all of you to take a look at this, particularly if we had people from the ministry, they really should look at this. Now, this is the US and the UK. What about developing countries? Well, we heard today, worldwide, there are about 160 new cases of cancer, 90,000 deaths a year. 80% of children live in developing countries. You all heard the results are very good in the developed world, and wherever, excellent cancer centers have been set up, but there are tremendous health disparities. And to improve the lives of children living with cancer in the developing world, pediatric cancer centers need to be established where we can offer multidisciplinary comprehensive care and with research and training. And this is a map of the world showing you the incidence of cancer in the colors and the deaths in the white. You can see that in places like Africa, most of the children diagnosed end up dying, whereas in Europe and the US, it's only a minority that end up dying. And we really need to focus on decreasing this disparity and improving, as Rick Shadia said this morning, the lot of these children living in low-income countries. Another statistic that's important and should be factored into how to do and develop a pediatric cancer center is that health expenditure, this is not on cancer, just total health expenditure by different countries, is directly correlated to survival of childhood cancer. So in countries that spend more money, you have the highest rates of survival, and in countries that spend little money, you have lowest rates of survival, and in between is somewhere in between. So how much the country and the authorities are invested in improving the health of the population reflects directly on survival from childhood cancer. Again, this is in a paper from Dr. Galindo from St. Jude, where it shows that this is the parts of the world that where you have increasing diagnosis of cancer, you have improved survival or decreasing death, meaning that if you have the facilities to improve diagnosis, you have the ability to improve care. Now, again, to summarize, what are the components of a pediatric cancer center that need to be in place? You need teams of specialists, including physicians, nurses, pathologists, radiologists, and so on. Standardized treatment protocol that have been developed and tailored to the population setting. We need to have palliative care, supportive care, and family-centered care in the patient education arm. Training in all functions of the center, physicians and nurses need continuous specialized training. Data coordination is needed, and there is a need to establish registries, as you heard. Others, cancer prevention program, community outreach, fundraising is very important, and collaboration between governments, the hospital, and non-governmental organizations. International collaboration is critical. To be a national center of excellence in the developed world, collaboration with an international center is essential. And to have the center as a local resource that's extended to the community, this backbone of international collaboration is needed. This also facilitates training opportunities, benchmarking, and exchange of expertise. It enhances state-of-the-art research collaboration, and it also improves funding. Challenges. In the developing world, there might be other health priorities for the expenditures. Maintaining the international collaboration is a challenge, as Sima definitely knows. Mixture of public and private funding, it's essential, but not always easy. Awareness of the disease in the population and the effect on outcome, symptom intervals, delayed diagnosis. Acceptance of the use of certain drugs for palliative care, need for population-based registries, training and retention of staff, and competition that's sometimes needless and destructive. Again, quality improvement is important. I stole this slide from Sima because I went through her presentation last night. And once all these are in place, okay, quality improvement can come in, but as she mentioned, we don't need to do it all at once, and we don't need all to be black belts. But we need, to strive to be there. Now, there is a coming wave. The next wave is the different rates of adolescents and young adults, 19 and 45. And this group is going to be an increasing proportion of our population. And they have different cancers that are increasing in rate, anorectal, leukemias, some types of lymphomas. Fortunately, they have some cancers, cervical cancer, lung cancer, that are decreasing due to the vaccine and due to smoking prevention programs. But this is a population that has a huge cancer burden all over the world, and it's going to be the next challenge for health planners and developers. Well, once we have the cancer center in place, we need to have research and care consortia, like COG in the US, where it's maximally experienced consortium, and young consortia like POEM. And this is again from the same publication by Dr. Carlos Galindo, but it's very, very useful to define how these consortium can be followed and developed. Now, I wanted to have a summary slide here, but I thought I would present this, and based on our experience in CCCL, a while back, we were asked to write a review about acute lymphoblastic leukemia in low and middle income countries. And this is we wrote it, so it must be beautiful. It's a good article, and we summarized the important things, is that the development of protocols that outline diagnostic evaluation, training and education of physicians, nursing, and staff, data gathering and management, case-by-case review internally. Now, when I was going through the US criteria, having a tumor board and multidisciplinary conferences are critical and essential for these cancer centers. availability of support care facilities and programs, the development of strategies to prevent abandonment. Fortunately, that's not at all common here, but it is, and public-private partnerships are important. Now, successes are great, but all of us need to do better. And I keep in my office this very beautiful painting by one of our patients who passed away a while back. He was a bright and energetic young man who had ALL. And he relapsed. He went even to St Jude, but unfortunately all the efforts failed and he left us. But I hope he's in a better place, and that will all go through the rainbow, and no child should die in the dawn of life. Thank you.
Thank you, Sima and Dr. Abboud, for Miguel, for this review on St. Jude and the Cancer Center. So we would like to open the panel discussion, and I thought I'll start very briefly with Sima, just to ask her, what do you think are the main impact of having St. Jude on pediatric oncology?
I think that at St. Jude, a main advantage we have is that ALSAC provides the funds, so if we have ideas to advance research, they are not limited by the availability of funds. So with that, we were able to pioneer the treatment of leukemia and then do all the research around the treatment. So we were the first center to drop radiation, the first center to start prophylactic irradiation in leukemia, the first center to drop irradiation and continue with chemo, and then the first center to discover that some children cannot tolerate chemo for genetic reason as much as other. And as we are going global, we are starting to be the first to report the genetic differences among the population, first as far as susceptibility to leukemia, then as far as having a harder to treat kind of leukemia. And then, of course, how much, as Dr. Mu'ad said, they can tolerate the treatment. I'm saying leukemia, but this goes to all cancers, just that leukemia is my passion. So I think we are always pioneering because we have the concept of PINKLE, of researcher working with clinician or clinical investigator hand in hand, and the kid is the focus, and we're always going to the next level, and we share what we find with everybody else, so we disseminate the knowledge. And of course, I can list a list of researchers, but I gave you some ideas. And
thank you, Sima. Since we have three of the panels here from three different hospitals in Lebanon, I would like to ask you about the collaboration with St. Jude and how you are using the expertise in St. Jude and how you're collaborating with each other at different levels, treatment, research, and Peter?
It's very important to collaborate all together because we need to have the same outcome in the same country. For this reason, I think one NGO or one center cannot alone do all the job. We have around 250 new cases per year. St. Jude can handle or can take 100, I don't know. So there are 2/3 of the other patients in different centers, what we are here from different centers. So it's very important to collaborate in the same protocols and the same way of treatment to have the same outcome. For this, for example, in Jaitawi Hospital and Room, we are working with St. Jude since 15 years, and we are using the same protocols. Even we collaborate if a patient cannot continue the treatment in our center, he can move to St. Jude and vice versa. We have done this several times, and we hope that we will continue in this field and this optical view.
Thank you. Gladys, Eli, you share the same.
أنا أول شيء بدي أشكر الكل اللي سمح أعطونا الفرصة نكون معكم. ميرسي كتير للإنفيتيشن وميرسي إلى هالميتينج اللي كتير منيح اللي اشتغل على عدة تايب أوف تريتمنت، يعني مش بس العلاج مهم، غير شيء مهم، يعني الريسيرش مهم، المانجمنت مهم، البسيكولوجيك أسبكت مهم، يعني تيم وورك كتير مهم بالنسبة لنا لعلاج مرضانا. أما بالنسبة للسؤال فعلا يعني أنا جيت مش من شي 10 سنين على لبنان، وبنظري إنه لبنان بلد صغير فما لازم يكون عندنا عدة بروتوكولات وعدة سنترات وكل واحد يعمل على ذوقه. فالأضبط ما إنه نحن منا كتير كعدد population منا كتار، ما بتطلع ديبارتمنت بفرنسا أو بأمريكا. فالكولابوريشن تيم أو الكولابوريشن وورك هو كتير منيح، يكون عندنا بروتوكول واحد للكل كتير منيح، ليكون عندنا بعدين ديسكشن ونعمل يعني داتا وكويستشن مارك، يعني ليه هي صار معنا هيك، ليه صار معنا هيك، بشكل كتير ساينتفيك واي. فأنا كتير مبسوطة انه نكون فعلا فرد بروتوكول كلنا سوا، ونجتمع من وقت لوقت وناخذ الأمثلة من هالبروتوكول لمرضانا ولبلدنا.
Thank you, Gladys. Ili?
The importance of a teamwork is for me the first thing that we should do, especially in our country where the lack of teamwork is always present from the head of state until the basic Lebanese population. So it's very important because no one can succeed alone. This is important of teamwork. And it was a little bit difficult at first when we started the collaboration because we have only so many ideas, and the background is different between the French school, the American school. But with time and with communication, I think this is the best way to improve and to continue, especially when we have some questions regarding the protocols, the outcome. We need to sit down and work it together, especially when we send patients for expertise opinion, especially for limb salvage or neurosurgery or even radiotherapy, and we can recover those patients back